Good evening, everyone. I mean, it's time to take a break from the medical oncology topics. I see very few surgeons here. Can we have show of hands? Yeah? Okay. So 2 surgeons. But it's always so interconnected. So it's always nice to know what's happening in each other's specialty. Interesting topic. A lot of times we are in a big fix, whether we should be salvaging our patients or not. So it's a review, it's a systematic review and meta-analysis. Now, this is the garden variety of recurrent cancers that we get to see in our clinics. Now, why are we discussing? This is primarily for the juniors and the youngsters who are sitting in the crowd. How is the recurrent cancer different from the primary malignancy? One, biologically, these are more aggressive, they are more infiltrative, they are generally multifocal, and they tend to throw microscopic deposits submucosally, and it would be seen beyond the radiation field, the previously treated radiation fields. And quite a good number of times, you cannot even clinically assess or radiologically evaluate. And also, they show extensive perineural invasion. Because of the previous treatment, there would be a lot of radiation fibrosis if they have been radiated, and there would be altered anatomy if they had been operated. So when you are handling recurrent cases, these are 2 clinical situations that you would be facing. And for the pathologists, it becomes a task if you have to do a frozen section analysis for your margins. The challenges are salvage surgery. There would be some permanent loss of function. There would be visible deformity. It does entail a lot of cost factor and mortality. So what we need to do is a good counseling of our patients. You must give realistic expectations. The patient should know what he is going in for. What are the various complications and side effects of the treatment that you are offering? And also the functional outcomes have to be clearly defined. So all this would be part of our counseling. So the facts are, 1, why are we talking about this topic is because 25 to 48% of our advanced cancers which have been treated non-surgically would fail. And these recurrences, 90% of the times, occur within the first 2 years. And the benefits of a cure that we are telling our patients, do we justify with the morbidity that we are giving and the poor quality of life? And the last statement, a long disease-free interval, you would realize that salvage surgery, vis-a-vis the non-surgical procedures, salvage surgery always scores higher. So what is it? It's a trade-off. It's a fine line between the treatment morbidity that we are giving and the potential to cure. We have a lot of retrospective data, but then the data is quite scarce. And most of the figures quoted are 5-year overall survival, which is 6 to 70%. So you can see a huge range. And why is it so? Because majorly these retrospective studies are small. You'll find a lot of heterogeneity in the patient characteristics, the primary treatment which has been offered to the patient, the type of salvage surgeries which have been performed by the surgeons, and also whether these patients received radiation or chemoradiation post-salvage surgery. One of the most quoted meta-analysis, and that's by Goodwin, and this was published in Laryngoscope in 2000. This is a meta-analysis which was multi-centered, multi-centric, 32 different institutions with a patient number of 1633, but ultimately the compilation was done on 1080 number of patients, and this was carried between 1980 to 1998. There was another part of the study, which was a prospective observation study, which was carried on 109 patients. So what were the endpoints that they measured? One was the overall survival, the disease-free survival, the surgical complications, and the operative mortality. What did we see? What we see on the table on the right side is overall the figures, the 5-year overall survival of all the anatomical subsites in the head and neck with salvage is 39%. and the 2-year is around 51%. But if you look at the anatomical subsites, the subsite which has scored highest is the larynx. So the larynx, and especially if you catch them early, and you look at the 5-year and the 2-year disease-free survival, it's fairly high. It's around 80 to 90%. While on the other hand, the oral cavity is lower, and the lowest comes into the pharyngeal cancers. So what is the clinical implication? Clinical implication is, one, you should keep your patients under surveillance. That is being shown by the other prospective study, which we realize as the stage of the recurrent cancer. The table here, I wish I had a laser pointer. The stage of the cancer, we've been able to offer this to a lot of our patients. So this is a trade-off between treatment morbidity, toxicity, and a potential to cure. What are the questions? Unanswered. That's whether salvage surgery versus salvage re-radiation or chemoradiation in resectable lesions, is it going to give an improvement in overall survival? One. Second, will immunotherapy at any point of time take away the place of salvage surgery? And the third is whether salvage resections vis-a-vis palliative, does this give a good clinical quality of life? And this, of course, is a picture of how we have salvaged our patients. Right selection, and you can get right patient, and you can have very good cure. Thank you so much.